Hello everyone, welcome to this flipped class. In this case we're going to talk about the obsessive compulsive and related disorders. And before starting, I just want to highlight that these disorders, or at least the obsessive compulsive disorder, was considered to be an anxiety disorder before, in the previous edition of the DSM series. And this has to do with the fact that there is anxiety, as we're going to see, involved in most of the features of at least of the OCD, the obsessive compulsive disorder. So let's start actually seeing what these disorders are characterized by. The first thing that they have, as the name says, is obsessions, which are recurrent and persistent thoughts, urges, or images that are experienced as intrusive and unwanted. So the person is doing whatever he or she is doing during the day, and then these unwanted ideas, these unwanted urges come to mind, and they get present. And I want to highlight that because that gives us a lot of insight about the functions and the psychological dysfunctions that could be present in this case. Then we have compulsions, which are repetitive behaviors or mental acts that an individual feels driven to perform in response to an obsession or according to rules that must be applied rigidly. So the compulsions are in response to this obsession, or just the response to rules that must be applied rigidly. Usually we understand these disorders in two moments, and we're always trying to see where's the obsession and where's the compulsion. Just like in the anxiety disorders, we're looking for the anxiety or fear, and then looking for where is the avoidance, or how does the person manages that? What does he do in order to manage that situation? Then the chapter also brings some other disorders that are recurrent body-focused repetitive behaviors. We will see how these disorders actually list some of the most important features regarding the body, regarding the preoccupations and worry about the body. All right, so let's start with the obsessive compulsive disorders. Here we have a very important issue in criteria A. We can have obsessions, compulsions, or both. This is important because we sometimes think that both things have to be present, and in fact that is something that is going to be repeated in the rest of the disorders. You don't have to have both, but it is very usual to have them both, and we'll see why. Because obsessions are defined by, as we saw, recurrent and persistent thoughts, urges, or images that are intrusive and unwanted. The individual attempts to ignore. This could be one of the outcomes, the avoidance, but this is a cognitive avoidance, or suppress such thoughts, urges, or images, or to neutralize them with some other thoughts or actions. And the compulsions are defined by 1 and 2. They are behaviors or mental acts that the individual feels driven to perform in response to an obsession. So, or according to rules that must be applied rigidly. We just said that one. But this is the important part. The behaviors or mental acts are aimed at preventing or reducing anxiety or distress, or preventing some dreaded event or situation. So this is the reason by which they always come together, because if someone has these kind of obsessions, there has to be a way in which the person is handling them. So the person does something with these obsessions because these obsessions are unwanted and they bring up anxiety. So usually we have compulsions. And we also see that compulsions can be mental acts. For example, praying, counting, repeating. Compulsions could not be evident to the light of a behavioral observer. And the person can be counting or can be praying without actually notifying no one else. Okay. The obsessions or compulsions are time consuming, and they take more than 1 hour per day in order to be considered a disorder. So a person who actually has these kind of things but only are present during a part of the day, or only are present during being present of a stimulus or something like that, then we couldn't say we have a disorder. But we obviously know there are some traits and there are some symptoms that could not clinically be taken for granted. Now, these are the rest of the criteria, which I am not highlighting that much because have to do with when they are not attributable to another substance or another medical condition. But here I'm adding this because the DSM-5 gives us this. With good or fair insight, with poor insight, or with absent insight or delusional beliefs. This has to do with the fact of how bad is the person in terms of actually being aware of or conscious of the disease. And this is very useful for the clinician in order to know the whatever the tools or the treatment he's going to take or she's going to take, but also in terms of how severe the obsession is or how close to another kind of clinical scenario we're talking about. For example, when we have delusional beliefs, then we may be talking about something else. Then we have the body dysmorphic disorder, which is a preoccupation with one or more perceived defects or flaws in physical appearance, but that are not observable or appear slight to others. So if you have I don't know, maybe a scar in your face or a birthmark or something that could be just normal to somebody else, there is a very high level of preoccupation. And this preoccupation is what we would say is the obsession. Another, the rest criterion is that the person has already done something about it, maybe a surgery, and usually we have surgeries about this kind of. So this is the people that is actually obsessed with their physical appearance, and that they have already done something to solve it. The appearance preoccupation has nothing to do or should not be considered if there is an eating disorder preoccupation, because this is a very common thing when we have an eating disorder, that the preoccupation has to do with the body feature. And then we have again the specifiers, if it's a good or fair insight, with poor insight, or with absent or delusional beliefs. This also gives us a very important information in order to know what to do when we're dealing with this kind of disorders. Then we have the hoarding disorder, in which if we want to look for the obsession, this is a very behavioral description: persistent difficulty discarding or parting with possessions. And here is where we have the obsession. This difficulty is due to a perceived need to save the items and to the stress associated with discarding them. So we have the obsession here of a perception of actually needing to save them. When you ask these people what is the reason by which you are keeping all this stuff, people usually say that they cannot think about leaving them or throwing them away, and the obsession is to actually keep them. Okay, and here we have that distress if you discard them, so that would be the outcome. Then the difficulty discarding possessions results in the accumulation of possessions. So these are people that actually have their houses completely full of stuff, in a way in which you cannot enter the room because it's full of rubbish, it's full of things that are not sorry, that was a light, that are not important or that are not useful for anything else. If these rooms have been cleared, it's only because somebody else did it. They won't do it. Okay, let's go to the next one, trichotillomania. This has to do with a recurrent pulling out of one's hair resulting in hair loss. This is people who actually pull their hair and up to a moment in which they are completely bald or they just don't have hair in that part of the body. But here we have repeated attempts to decrease or stop the hair pulling. So where's the obsession here, or where's the compulsion? We see here that we may not have an obsession, but we do have a compulsion. The pulling the hair is the compulsion. They cannot stop doing it. Now the obsession is not as clear as in the rest of the disorders, but there should be an obsession in each person in order to do it. And if it's not, we could say that we can already consider this as an obsessive compulsive disorder, because you don't have to have both. Only with one is enough. So let's go to the next one, excoriation, skin picking. This is very similar to the hair pulling because it is about picking the skin, resulting in skin lesions, without actually having a motive, a reason by doing it. And there's also repeated attempts to decrease or stop skin picking, but they just can't. This could be related with people who actually cut themselves, but because it can come into skin lesions, but this has more to do with actually picking the skin, and there's evidence that there's skin picking more than skin cutting. So where's the obsession here again? We only see, or it's more likely to see the compulsion instead of the obsession, and that is because maybe the reasons by which the skin picking takes place are not present or are not as evident as the compulsion. These are all of the criteria present in the chapter. Thank you very much.